Well, good evening to all of you, and it's a great pleasure to talk about heart failure and what's on the horizon. My name's Martin Cowie. I'm Professor of Cardiology at Imperial College in London and head the heart failure service at the Brompton Hospital. These are my declarations of interest. And what I'd like to cover quickly today are three topic areas. One is about new drugs for heart failure and focusing on heart failure with reduced ejection fraction. Then on the problem of heart failure when the ejection fraction is preserved, or HFpEF, and then a look to the future in terms of digital technologies and how that's changing the way that we interact with our patients. So let's do a quick update on trials. You've probably heard of these, but I'll just give you some detail and my own interpretation of these. And the major breakthrough class of drugs in recent years has been the SGLT2 inhibitors. So as you know, they block the SGLT2 co-transporter system in the proximal tubule, get more glucose into the urine. So we've known for a long time that this can improve diabetic control in type 2 diabetes. But as you can see on the slide, there's lots and lots of other actions of these drugs, which are probably beneficial widely for the cardiovascular system. However, there was a trial program that was set up because the FDA mandated safety trials to make sure that the cardiovascular outcomes were not worse with these drugs. And of course, how surprised we were when we actually saw the cardiovascular benefit right across the board for SGLT2 inhibitors. So these trials on the slide, EMPA-REG, CANVAS, DECLARE, VERTUS, you've all heard about. VERTUS was just published a few weeks ago, but all of these looking at type 2 diabetic patients, a reduction in 3-point MACE and cardiovascular death or heart failure hospitalization. And if we actually look at the data for heart failure hospitalization, that is where most of the benefit seems to be. And these are big reductions on top of standard therapy. Many of these patients were on ACE inhibitors, for example, many of them on antihypertensives. You can see a 30 to 35% reduction in the risk of heart failure hospitalization in these patients with type 2 diabetes. A very strong signal also for kidney outcome, which we don't really have time to talk about today, but you can see this big impact on improving both heart failure and kidney outcomes in these patients with type 2 diabetes. However, if we think about heart failure, they then set up trials to see if these drugs were helpful in patients with HFrEF, and whether they had type 2 diabetes or not, because of these broad spectrum of effects that seem to be beneficial. So the first trial to be published was Paragon HF in 2019, and this is 4,700 patients with heart failure with reduced ejection fraction, about half and half diabetics and not diabetics, so broad range of HFrEF patients, followed up for an average of 1.5 years. Main result, 26% reduction in the risk of worsening heart failure or cardiovascular death, and actually, statistical terms, nominally, a reduction in cardiovascular mortality and also total mortality. So patients lived longer with being treated with dapagliflozin, an SGLT2 inhibitor, if they had HFrEF, and this was on top of ACE inhibitors, beta blockers, and many were on aldosterone antagonists. So big positive for dapagliflozin in 2019, and in fact the drug's been licensed by the FDA in the USA for the treatment of HFrEF, whether you've got diabetes or not, and the European Medicine Authority is about to issue a license which is very similar as well for dapagliflozin. But it's not just for that drug. A trial that was just presented a few weeks ago at the ESC, Emperor Reduced. This is empagliflozin, another SGLT2 inhibitor, very similar population, perhaps slightly higher risk, heart failure patients. And you can see here that once again, 25% reduction in heart failure hospitalization or cardiovascular death. So very positive for SGLT2 inhibitors, particularly dapagliflozin, for patients with HFrEF, irrespective of whether they have diabetes or not. So a lot of people are now talking about what is the basis of therapy. If you have a patient with heart failure, it's a low ejection fraction. Well, of course, you know about ACE inhibitors, angiotensin receptor blockers, and if it's possible, switching them to a neprilysin inhibitor like sacubitril/valsartan is pretty standard practice now across the world. Beta blockade we've known about for 20 years, start slow and gradually titrate up. Aldosterone antagonists, but now this fifth pillar of SGLT2 inhibition. So doctors are now getting experience of adding, for example, dapagliflozin to standard HFrEF therapy as a fifth pillar to improve outcome, both in terms of heart failure hospitalization risk, but also, to be honest, in terms of reduction in cardiovascular and all-cause mortality. So big change there in what the standard of care for HFrEF is becoming. What about HFpEF, where the patient has heart failure but the ejection fraction is not reduced? And this, depending on which country, I think in India maybe 20 or 30% of patients at most. In the UK, where I am, it's possibly 40% of patients. In the United States, maybe even more. It's a large group of patients with heart failure and preserved ejection fraction. Well, watch this space. Dapagliflozin with DELIVER is specifically targeting that population, and empagliflozin is also looking at this in Emperor Preserved. But we don't have the data yet, but look out for it coming through. Maybe these drugs will also be useful in the first class of drugs to be proven to be working in HFpEF. We don't know yet, but let's watch this space. Now, another trial which you may not have noticed because it came out just at the start of COVID pandemic at the virtual ACC. It's called the Victoria trial, and this was looking at vericiguat in sick heart failure with reduced ejection fraction. Now, this drug is a cyclic guanylate cyclase modulator. It increases activity. It's a vasodilator, and supposedly would be beneficial in the heart failure syndrome. So what was this trial about? They took patients with HFrEF and recent worsening. So these patients had largely been recently hospitalized or recently had intravenous diuretics. They all had very high natriuretic peptides. So this is the sick end of the HFrEF spectrum of patients. As you can see here, if I just draw my arrow down, heart failure hospitalization in the last 3 months for 2/3 of the patients, so very soon after discharge. And if you look here at class 3 or 4, 41% of the patients were symptomatic either at rest or on a very minimal exertion. So sick heart failure with reduced ejection fraction. This was a principal result. Now, if you're a positive person, you think this is really good. If you're a negative person, you think it's not so convincing. But let's just look at the data. So here's a 10% reduction in the combined endpoint of cardiovascular death of first heart failure hospitalization. So not like the 25% we were seeing with SGLT2 inhibitors, just 10%. P-value 0.02. So unlikely to be due to chance, and you can see the effect appearing here. If you look at the components of the primary endpoint, absolutely no signal for benefit in terms of mortality from cardiovascular death, and all of the benefit seems to be in heart failure hospitalization, first or subsequent hospitalization. So in other words, it stabilizes the syndrome in these sick heart failure patients, reduces the risk of them being readmitted, but probably no mortality benefit for this drug. In terms of tolerability, there was a little bit more hypotension and syncope. It's a vasodilator after all, a little bit more anemia. We're not clear of the mechanism for here, but generally very well tolerated and no impact on renal function, either positive or negative. So the drug is not yet licensed. It's going through regulatory consideration at the moment, but in terms of my opinion, this is much less of a useful drug compared to SGLT2 inhibition in HFrEF. It may be useful in sick heart failure patients that have been hospitalized, already in a lot of other therapy, so it's probably quite easy to add in and may reduce the risk of them being re-hospitalized. But that is the kind of evidence for the Victoria. Now, I would like to turn to the problem of HFpEF. So good news about SGLT2s for HFrEF with reduced ejection fraction. What about this group with heart failure with preserved ejection fraction? And of course, that's challenging to diagnose. Diastole is a more complex phenomenon than systole. It's three-dimensional. It's in 4 different phases. It's more difficult to assess. So the actual diagnosis of HFpEF clearly can be very challenging. The best approach currently is obviously the patient's got to have heart failure. So there has to be signs and symptoms of the heart failure syndrome. So you need to take a history and examine the patient as you would do. But then there's 2 key things to help you diagnose HFpEF. You can't just diagnose it based on the echo. It's not as straightforward as that. So what we use is natriuretic peptides, a simple blood test. You'd expect the peptide to be elevated in a heart failure syndrome, and then you have to do a careful echo and look at various measures on that to see if there is evidence of cardiac abnormality. We've known for decades, and you will know this as clinicians, that you cannot distinguish reduced ejection fraction from preserved just from history or for examination. You do have to do the imaging to work out what's wrong with the heart. And even the natriuretic peptides will not tell you whether it's HFrEF or HFpEF. You might have a greater elevation in HFrEF, but it's not clear enough distinction between the two. So natriuretic peptides very good at confirming a diagnosis of heart failure or ruling it out, but it doesn't tell you how the heart is failing, what the mechanism might be. So what do the guidelines say? And of course, they have changed over the years. There is a focus, and here's 2012 guideline from the European Society of Cardiology. So as I said, if you look at the arrow there, symptoms are typical of heart failure and signs, but the ejection fraction is well maintained. The left ventricle is not dilated, so therefore you're looking at other more subtle signs of abnormality in the heart. But you have to find something, otherwise it may not be heart failure at all. It may be an other condition. And I'm not going to spend ages talking about the different echo measures, but obviously it's looking at the structure of the heart, the size of the chambers, and the flow across the mitral valve particularly, but also how the ventricle relaxes is also important information. But it can become quite complicated, and for a clinician who doesn't have access to very high quality echo or has to wait a while, is there a simpler way of trying to do this? And there's been a lot of work in this space in the last year or two, so I thought I should put it into this lecture. People are trying to find a simple approach that's evidence-based and will help make a clear diagnosis of this condition. In summary, it's all about probabilities. You can never be 100% sure. It's a question of looking at the patient, the echo, and the symptoms. So here's a score called HFpEF. This is from the Mayo Clinic. And basically, you get points depending on whether you're obese, a history of hypertension, atrial fibrillation, older age, and also the Doppler abnormalities. And depending on the score, it will then give you a probability of this being HFpEF. Now, this is pretty good in the Mayo Clinic. It's splitting out those that have HFpEF from those that don't, and it does give a good estimation of risk, but you as a clinician still only get a figure such as it's 60 or 70% likely of being HFpEF. You still have to narrow it down and decide if that's enough evidence or not. More recent guidelines, and this is from the European Society of Cardiology, and it's called the PEF guideline. And basically it's what I've been saying to you: symptoms, signs, echocardiography, natriuretic peptides. But they recognize that for a lot of patients you still cannot make a clear diagnosis, and you may have to do a more detailed echo. You may even have to do a stress echo to see what happens to these measurements when the heart is stressed, bearing in mind, of course, that most heart failure patients have no symptoms when they're sitting at rest, when you're doing an echo at rest, and it's only when they start to exercise that they get symptoms, and therefore we should study the heart when it's under stress. But even then there are times when it's not a clear diagnosis, and I have these examples time and time again in my clinic. Sometimes I have to do invasive investigation to make a clear diagnosis, or other times it is just a probability of what's going on. And it can become very complicated very quickly. So this is in the document. I'm not sure any of us have the time to go through all of these characteristics of the echo, the natriuretic peptide, major and minor criteria. This is still difficult medicine. For some patients, with careful thought, you can make the diagnosis, but for many, they're in a grey area. But you could ask yourself the question, why spend so much effort? What treatments do we have for HFpEF? Obviously, if somebody has low ejection fraction, we've now got these 5 pillars of therapy that we can offer them, not to mention devices such as CRT or ICD. But what about preserved ejection fraction? Have we any options for these patients? So I'm afraid I put these tombstones here just to make the point that heart failure is still a serious diagnosis and serious mortality if it's not diagnosed properly or you get put onto the right treatment. But at least for HFrEF, there are now many evidence-based treatments in the guidelines, and in most countries, including India, you can have access to many of these therapies for your patients. For HFpEF, diuretics to reduce congestion and improve symptoms. But is there evidence for anything else? And I've put there 3 S's. Spironolactone, is there evidence? Sacubitril valsartan, is there evidence? And I'll mention a new trial. And then, of course, SGLT2 inhibitors. We're waiting for DELIVER with dapagliflozin and Emperor Preserved with empagliflozin to tell us about the role of those drugs for HFpEF. So what do the guidelines say? Well, on the left is HFrEF, a nice algorithm. I'm sure you're all very familiar with those drugs, and now the 5 pillars of therapy. On the right-hand side, this is all the guidelines say about HFpEF, and that is that treat the comorbidity, the obesity, the hypertension, the atrial fibrillation, the diabetes. Other than that, it's diuretics to reduce congestion. So very frustrating to treat. You've made all that effort to make the diagnosis with echo and blood tests, etc., and thinking about it long and hard, maybe even a stress echo, but then what therapy? And you're just left with diuretics and treating the comorbidities. But there's been a lot of effort to try and find therapies in this area. I'm not going to go through all of these trials in any detail, but just to say on the left, we had Charm Preserved with candesartan, we had PEP-CHF with perindopril, iPreserve with irbesartan, and then TopCat, which I want to spend just a second or two on. This was an aldosterone antagonist, spironolactone, which has been around for years. Could this make a difference for patients with HFpEF? Now, overall, statistically, there was no difference in cardiovascular mortality, heart failure, hospitalization, or cardiac arrest in the 2 groups. But then there was a lot of debate, which was very political also, about the type of patients that went into the trial. So in Russia and the Georgian Republic, the patients seemed to be largely just hypertensive patients with some echo abnormalities, not frank heart failure. So their event rate, as you can see in this slide, if I highlight it for you, was very low, probably just hypertensive patients. But in the rest of the world, patients who were recruited had a much higher event rate. This was probably heart failure. And there was better evidence that there might be a difference in terms of these hard endpoints with the use of spironolactone. But obviously, overall, the trial was not super convincing. So some doctors will use spironolactone, some will not in this syndrome. But subsequent studies and looking at the data, and this was published in 2016, so you may have missed this. This is looking at the ejection fraction range in TopCat, so from 45% right the way up. And if you actually look at the outcomes, the primary outcome or heart failure hospitalization, you can see there seems to be a gradient. So right up to 55%, statistically, there seems to be a reduction in the outcome, particularly driven by heart failure hospitalization. And that's a lot of patients in this lower end of the range. So not conventional HFrEF, maybe you would call it mid-range, but for me, it's just less systolic dysfunction. But if you get into the true HFpEF with preserved ejection fraction, clearly there doesn't seem to be benefit, but there is benefit right the way up to 55% ejection fraction with spironolactone in TopCat in this post-hoc analysis. So people then went back, and this is now 2018, and looked at the other studies. So here's the CHARM program, which narrowly missed finding benefit in HFpEF. Very similar picture again. If you look at heart failure hospitalization and even cardiovascular mortality, there seems to be benefit right the way up to 55% ejection fraction. So possibly we should be talking about HFpEF only being ejection fraction 55% and above, where we still have no evidence-based therapies. But for heart failure all the way up to 55%, then probably the standard therapy with ACE inhibitors, angiotensin receptor blockers, and also aldosterone antagonists will probably be beneficial, particularly for heart failure hospitalization. So let's look at this study. This is Paragon HF. So this is sacubitril valsartan, but looking at the HFpEF population. Now, they defined it quite broadly. So this was heart failure, but ejection fraction had to be 45% or above, had to be symptomatic, high peptides, and cardiac echo abnormalities. So let's see what's the effect of sacubitril valsartan in this population compared to standard therapy. And they compared it against valsartan, so it was an active comparator here. And I'm afraid, if you look at this, the end outcome was not statistically significant. It just missed it in terms of its primary outcome. But you can see also for hospitalization wasn't significant, and for mortality, very little evidence of benefit here. But what about this hospitalization benefit? Didn't quite reach it. Regulators still thinking about it, but not very enthusiastic about giving an indication here. But if you look at the subgroups, and I think this is very interesting indeed, there was a suggestion that once again, in that lower part of that series of ejection fraction, there was benefit from this sacubitril valsartan, particularly up to about 57%, which was the median in the study. Graphically, just show you here, and this just been published in Circulation. Once again, looking at the range of ejection fractions. So you're a patient with heart failure, get the ejection fraction. This is obviously reduced ejection fraction, and we know from the Paradigm study, very beneficial here, but you can see adding to that with the Paragon data, merging it together, there seems to be benefit right up to 55, 56, 57% in these patients. And the effect may be even higher for women, where normal ejection fraction may be well above 60%. So I think the take home from all of these studies is that if you're going to diagnose HFpEF, make sure it is truly HFpEF, make sure you spend time diagnosing it properly, but that really should only be an ejection fraction of 55% or above. That's HFpEF where we don't have evidence-based therapies, but below that with a heart failure syndrome, there's pretty convincing evidence that the standard approach of ACE or angiotensin receptor blocker or sacubitril valsartan and aldosterone antagonism is beneficial. So a really important practice point. Don't just treat those drugs for ejection fraction below 40, extend it right up to 50, 55% if they have the heart failure syndrome. So the last thing I wanted to talk about before questions, and hopefully we'll have plenty of time for questions or comments, is looking now more to the future and the digital aspects of care and care delivery. So in the past, of course, being a cardiologist, you spend a lot of time training, and then of course you saw the patient face to face. You would spend time taking a history, examining them, using your stethoscope, doing imaging, doing interventions. But I think what we'll see increasingly in the future is that our role will be extended and that it doesn't have to always be with the patient directly in front of you. And of course, COVID pandemic has accelerated this trend. So on the right-hand side, I put this picture. Yes, as a cardiologist, we're still involved, but our intelligence will be supplemented by artificial intelligence and machine learning. Patients now won't have to come to a healthcare facility necessarily to get data collected that might help us in our decision making. There's a lot more wearables and other technologies for remote monitoring and data collection. And the Internet of Things, where wearables, electronic medical record, other data sources can be integrated, kind of underpins all of this. And then, just to amuse myself, I put a little picture of a drone on this slide. So now even ICDs can be delivered to help in sudden cardiac death outside hospital, but also medication can be delivered or vaccines can be delivered to remote parts of a country automatically using such technologies. So there's lots of potential to this, but of course the challenge is, where's the evidence? How can we do this, and how is it paid for? But ultimately, it is about getting expertise to the patient and the family rather than them having to come to us. And digital, of course, is a normal part of everyday life. We all have smartphones, we all access our bank accounts, we used to make travel bookings on our phones, etc. And within healthcare, increasingly patient-to-patient communication, doctor to patient, doctor to doctor, and then within our organization, lots of digital technologies underpinning it. So it is already here. I chair the Digital Health Committee of the European Society of Cardiology, so we're very interested in cardiologists and other healthcare professionals in cardiac disease getting involved in all of these topics. So many of these are very familiar. The electronic medical record, e-prescribing, e-appointments, pretty standard across the world. Decision support is becoming more nuanced and integrated. And then, of course, there's a huge expansion of mHealth with apps on smartphones and wearables. And the COVID pandemic has accelerated people doing remote consultation and wanting to get into remote monitoring. So lots of these areas of cardiology are developing rapidly through this. And as I mentioned, the COVID has accelerated this by necessity across the world, but also made funders, insurance companies, patients even, more willing to pay for this, which also has accelerated it. Now, just one or two examples before I finish, just to make it more practical about where digital is making a difference. So this is the ECG. When all of us were training, the machine was relatively mobile, but you would have to come to a clinic or to a hospital to have an ECG recorded. By the time you arrived, quite often the paroxysm had settled and the ECG looked relatively normal, so very frustrating for everyone. Wearables were not that easy for patients, and often long waiting lists for that. Now, if you can afford it, of course, there are lots of consumer-facing technologies such as the LiveCore or even the Apple Watch, which have been approved as medical devices for recording lead 1 ECGs and for AF detection, etc. This is becoming more important in this process, although many people are concerned that too much data is being generated, too much anxiety, who's going to look at it, how can we get algorithms to make sure the workflow works. And of course, some of the big tech companies who have enormous budgets have done studies, real life studies, real world studies. This is the first Apple heart study, and this was before the ECG was there. It was more irregular pulse detection, which was then confirmed by a wearable patch. And you can see that a lot of the irregular pulse notification turned out to have AF on subsequent testing. The problem, of course, is that in the US, many of the people wearing an Apple Watch are young and at low risk of atrial fibrillation, and those at highest risk, the retired population and older, are unlikely to use this technology. So you have a mismatch between need and delivery of this. The other thing which I've highlighted in italics on the slide is that even people that volunteered in this study and they were told their pulse might be irregular, only 60% actually followed it up. So it's not just about the technology, it's about whether people are going to act on the data, whether they want further information, etc. So it's not just dropping technology, the human factors are hugely important. Here's another example. We all spend years training to use our stethoscope properly, but now, of course, you can have little devices that can record a phonocardiogram and send that audio file anywhere, or have machine learning or just a simple algorithm looking at it along with the ECG to come up with the diagnosis. And on the right, we now have robots that use machine learning to get the best possible images from ultrasound, and you can have AI to interpret the images and at least then reduce a lot of the burden of routine reporting before some human checks this. But in theory, you could have your echocardiogram done in a shop, and that image can be interpreted and sent anywhere in the world for somebody to advise you. So a real democratization, globalization of this process and getting nearer to where people live rather than them having to come to a special facility to very expensive equipment. But of course, there are challenges and problems as well as opportunities in this. Another example, if you come to London, once we can travel again on the Underground, you can see these signs, which is an app to give you primary care or GP. So a lot of young people, hundreds of thousands of them, resigned from their general practitioners. They signed up for this app called Babylon, and if they have any symptoms, they just type it into their phone, a chat bot, then ask a few questions, which narrows it down, probably reassures or points them in the right direction. If they're worried about things, then they can actually have a video call with a GP anywhere in the world, in theory, usually in the UK here, and that GP can then make a diagnosis, refer onwards, prescribe, etc. So this digital technology is really making it, especially for young people with smartphones, easier to access health advice. And also for doctors, they can do this work from their home or from wherever. So hundreds of thousands did this before COVID, and now, of course, even more people have signed up for this. And I think the final example I wanted to give you was the other wearables, such as Fitbits and other watch-like devices, but also things that can be worn into smart textiles or worn on the body, can give you a lot of information about many different physiological parameters that you might want to use as a doctor. Heart failure, which is my own specialty, of course, has always been interested in remote monitoring because, as we know, many patients deteriorate, they don't notice, and they only present as an emergency when things are quite extreme. So can we use technologies, either standalone or implantable technologies, to monitor patients remotely? There's been a lot of work in the last 20 years on this, quite challenging to find a solution that works, that doesn't give false positives or just increase the workload without improving outcome. But I think we're beginning to see where this is going. The technologies are improving, the machine learning is getting better, and probably within the next 5 or 10 years we will find a solution that matches the need. But the ultimate objective is that if you have a cardiac condition, you can use technology to monitor that, to adjust things, and you don't need to have so much contact with expensive, very busy healthcare professionals. And in many countries, such as India, such as UK, such as many parts of Asia, there are just not enough doctors to deal with all of the medical issues. So it's quite an attractive issue. I just want to very quickly say it is not by any means easy. So lots of studies have been looked at in terms of the results. I'll just skip on to here. So initial very small studies in expert centres were hugely enthusiastic, but unfortunately, when it went on to larger trials with thousands of patients and many centres, many of these studies were completely neutral. So you don't improve on specialist outcomes for patients, but you can certainly get an outcome that's very similar to that with this remote monitoring type technology. There's a lot of excitement, and I don't know how relevant this is, but if you have patients with CRT or ICD, you can get lots of extra information from such patients, and you can use that to monitor them remotely. It can cause problems. So here's one randomized trial I was associated with, where we actually increased heart failure hospitalization by 80%. And this was triggered by transthoracic impedance. Now, you would have thought that was a great way of doing it. The lungs get wetter, the impedance drops, and therefore the heart failure is getting worse. So they built in an audible alarm in the device. Patient would be woken up, they'd hear the alarm going off, and they could ask for help. The problem with this was there was too many false positives. It would go off, the patient would become anxious, the family would then become anxious, and the patient would go to the hospital. The physicians examining the patient didn't know the patient. They said, well, you seem okay, but your device is alarmed, so let's admit you just to be sure. These are very short admissions. Very few people died during them. This was just a false positive, and things probably would have re-stabilized on their own. So this study had to be stopped because this particular use of this parameter, this technology, this chain of action led to a big increase in hospitalization rather than a decrease. But there is hope, and the CardioMEMS device, an implantable pulmonary artery pressure monitor, expensive, but if a patient can be eligible for this, the evidence suggests from both randomized trials and a lot of post-market surveillance that this can have a huge impact on sick heart failure patients, NYHA3, whether it's HFpEF or HFrEF. If you manage the pulmonary artery pressure down and keep it down, you reduce hospitalization. The initial randomized trial was only in 500 plus patients, showed a big reduction, about 30% reduction in hospitalization, and the effects are probably even larger in now routine studies in Europe, Australia, North America, where the closer attention, the patient more involved, better use of drug therapy seems to make a big difference for NYHA class 3 patients, and now in the States a class 2 study is underway. But this is a vision for the future for all of us, that patients will expect to be able to access advice more easily wherever they live. That will involve remote type consultation and monitoring, and understanding how data can be used for benefit. And we as cardiologists will probably only be involved where our skills are really needed. Now, it's a great vision. It will take some years to get there. I'm sure there will be problems, but it's a very exciting new world, and particularly for complex conditions such as heart failure. The challenge, of course, is the kind of patients that we have to deal with. So some are very educated, some have money to buy technology, some are really interested in that, but many patients are not like that. And even in wealthy Western Europe, latest surveys show that the understanding of health and medicine is very poor in populations. They don't understand how their bodies work, they don't understand the reasons for taking medicines, etc. And that doesn't improve, even if you have a chronic condition. So at least half of the European population, despite high education and high relative wealth, are really not very knowledgeable about health, and many of them are not very digitally literate as well. So that's 35 minutes. We've got plenty of time for questions, but I hope I've given you a flavour of how exciting heart failure is at the moment in terms of all the trials that are coming through for medicines, and particularly SGLT2 inhibitors, which really seem to have really beneficial effects for the heart and the kidney across a broad spectrum of patients. The challenges of diagnosis for heart failure, particularly heart failure preserved ejection fraction, but also I hope I've given you some hope that the fact that you should really be using these standard HFrEF drugs probably right up to an ejection fraction of 50-55% if the patient has heart failure. And ultimately, we all have to get involved in the conversation about digital co-design of the future. How does the technology help us? Are we sure it helps us? How do we make sure it is used for good rather than just complicating the issues? So heart failure is very exciting, and it's great to spend some time sharing my vision, at least, of where things might be going.